Layla Abushmat.
Correct.
Okay, come on up.
Right. Good afternoon, everyone. My name is Layla Abushmat. I'm a fourth-year medical student at Tulane. I'll be presenting today a case of Metformin-associated lactic acidosis in the setting of hypovolemia. I'd just like to acknowledge my co-authors, Dr. Tankam Nair and Dr. Rajiv Vatsabai. I have nothing to disclose. Today we're going to talk about metformin and its side effects and where they're pertinent in certain clinical settings. We're going to talk about the different types of lactic acidosis and then also the general criteria for metformin-associated lactic acidosis. So diabetes has a large disease burden in the United States. As you can see, about 8% of the population has diabetes. In Louisiana, where I go to school, it's about 10%. So it's definitely a large disease burden. And then the disease burden is expected to increase. The incidence of diabetes continues to increase as obesity continues to increase in the United States. And since it's a chronic condition, the prevalence will continue to increase. So the American College of Physicians recommends metformin as initial pharmacologic therapy for type 2 diabetes. That's when a patient starts on lifestyle changes, metformin is always the first one. And since there is going to be a lot of diabetic patients in the future, everyone's going to be started on metformin initially. And so knowing the side effects of metformin and when to consider them is very important. So my case presentation is a gentleman, A.L. He is a 45-year-old male. He presented to the ED with 2 days of nausea and vomiting. He also had an episode of diarrhea, and he also complained of fatigue, poor oral intake, and headaches. He did have a past medical history of hypertension. He's been on amlodipine and benazepril for that. Type 2 diabetes, which he's on sitagliptin, metformin combo, and a glimepiride. And then he's also has hyperlipidemia, for which he takes niacin and fish oil. He's a car salesman. He was a former smoker, but he doesn't have any alcohol or illicit drug use that he mentions. So on physical exam, the only pertinence really was that he was lethargic. He was oriented to person, place, and time. His vital signs, though, were important, though. His blood pressure was 93/61, heart rate of 124, normal temperature, but respiratory rate of 18, and oxygen saturation of 98%. When we started doing investigations, his initial electrocardiogram was sinus tachycardia, but his x-rays were all unremarkable, and then his urine drug screen was negative. So here, taking a look at his labs. So initially we can see if this laser pointer works, it doesn't work. But if you can see over here at the arterial blood gases, he does have an acidemia. If we look over his bicarb, it's less than 10, which our lab only detects greater than 10. So since it's less than 10, it was undetectable for us. And then if you look at the anion gap, it's 30.9, almost 31. So he does have a wide anion gap metabolic acidosis. Now thinking about the different reasons for that, we can look over, we do see that he's an uncontrolled diabetic. His hemoglobin A1C is 9, but his glucose wasn't too bad. It's a little elevated, 185, but not something suggestive of diabetic ketoacidosis. He only has +1 ketones, which could be explained by his dehydration. And then we can look up and calculate his osmolar gap, which here just measured minus the calculated. We can see he has an osmolar gap of 19. Anything above 20 would be suspicious of alcohol in his system, any kind of alcohol, so methanol, ethanol, and all that was negative on urine drug screen as well as in his serum. And so between 15 and 20, we want to consider ketoacidosis, lactic acidosis, renal failure, or any kind of critically ill patient with hyponatremia. So just looking at that, we can see that his creatinine's 2. He doesn't have a history of chronic kidney disease, so it's probably acute kidney injury. And then we can go down and look at his lactic acid. It is elevated at 8.1. So his cause of his metabolic acidosis is likely lactic acidosis. Now thinking about different infections, his urinalysis doesn't really have any infection. His blood cultures while during the hospital stay had no growth, and then his x-rays were negative. So at this point we weren't really thinking about infections. So over the next few hours, he deteriorated, became obtunded. He eventually actually went into asystole and was resuscitated with bicarbonate and atropine. At that time, though, his potassium was 6.2, which is likely the reason for that. He was intubated, placed on mechanical ventilation, and then started on 24 hours of continuous venous hemodialysis with a bicarb buffer, where his mean arterial pressure was supported with epinephrine and vasopressin as well. So within 10 hours, though, his lactic acid level went down to 1.9, and he was actually extubated, and dialysis was stopped on day 2 of his hospital stay, discharged from the ICU on hospital stay day 3, and was able to be discharged home on day 6, back to his present baseline condition. But then on further investigation, we did notice that his metformin level on admission in his serum was 9.7, which is almost 5 times above the upper limit of normal, which therapeutic range is about 1 to 2. So he was admitted with wide anion gap metabolic acidosis, as I mentioned earlier, with a severe lactotemia and acute kidney injury. And his acute kidney injury is probably because of his severe dehydration and his hypotension, and then it was exacerbated by the fact that he was on an ACE inhibitor during all this acute illness as well. So just going over the different causes of lactic acidosis, there's type A, B, and then D lactic acidosis. The D lactic acidosis is the one that's typically associated with short bowel syndrome, but it could also be seen with diabetic ketoacidosis and propylene glycol ingestion. So that's not something that we're really worried about with this patient. As far as type A lactic acidosis, the definition is anything that causes decreased tissue perfusion. So that could be shock, anemia, hypoxemia. And for this patient, definitely that does play a role. However, the degree of his lactotemia is pretty high. So go into type B lactic acidosis, you can see that it's typically associated with use of biguanides. That's the famous one. But it can be associated with other drugs as well as some malignancies. So the only biguanide in the market in the U.S. is actually metformin. Metformin is thought to act by decreasing glucose uptake at the liver and then increasing glucose uptake at the periphery, keeping blood sugar levels low. And however, it does rely on kidneys to be normal for it to function. So the main side effect for many patients is they complain of gastrointestinal upset, but one of the rarer side effects and the more dangerous side effects that are noted is the lactic acidosis. And however, this is very rare. As you can see, only 1 to 8 cases per 100,000 patient years. But then at the same time, there are contraindications for use, and it's thought that patients who have any of these disease states shouldn't be on metformin because it does put them in an increased risk for lactic acidosis. These include the renal insufficiency, hepatic, cardiac, or respiratory insufficiency, and then any kind of severe infection or hypoxic condition that can cause that type A lactic acidosis as well. Now, the mechanism of action that's thought to occur for metformin to cause lactic acidosis is that metformin, when in excess, will inhibit glycogenolysis and gluconeogenesis. And so this causes lactate to build up in the blood and then therefore lowering the pH in the blood. However, to date, there's no correlation between metformin levels being high and lactate levels being high. And it's actually a matter of controversy in the literature. Every case that we have is only a case report. All meta-analyses have found no link between the two. And often these case reports include patients with comorbidities that complicates this link. And so there have been general criteria that have been proposed for these case reports, and basically they're very general. Arterial pH of less than 7.35, so the patient's acidemic, and then having a lactate concentration of above 5, and then a detectable metformin level. So actually there was a database that went through looking based off of these guidelines or these criteria to see how many case reports tagged with metformin associated lactic acidosis actually followed these guidelines, and only 10% of the reports actually followed them. As a rebuttal, however, metformin is very difficult to measure in the blood. Depending on the presentation, it can be very high or it can be undetectable. And then it's also very difficult to measure in the hospital as it's not a routine lab at all. So there would be a time lag associated with the results. However, our patient did have a pH of 7.012. His serum lactate was 8.1, and his metformin level was 5 times above the therapeutic range. There's no source of infection identified. His initial labs were not suggestive of diabetic ketoacidosis. And then no other chemicals that are typically associated with anion gap metabolic acidosis were found in his blood or his urine. So just going over the case a little bit, so his creatinine of 2.1 was likely an acute kidney injury, likely secondary to his dehydration and his use of his ACE inhibitor. But then in this setting of renal insufficiency, he was able to build up metformin in his blood, causing there to be toxic levels. Now, why is this significant? Like I mentioned before, most of our diabetic patients are on metformin. Many of these patients who also have hypertension are placed on an ACE inhibitor because of the fact that it's been shown to reduce the incidence of microalbuminuria in these diabetic patients. And so dehydration can also occur very easily. Any gastroenteritis or acute illness can cause dehydration, even working outside on a hot day. And so it's worthy to be vigilant about these different settings, maybe even telling patients that when you get sick to stop your metformin for a couple of days, because something like this can happen to any one of those patients. It's very common. Here are my references. Thank you so much. I guess we'll hold questions till after my colleague presents.